crack on. We'll talk about cholesteatoma now, my favorite topic. So, so this is the scope of the lecture. We'll talk about pre-operative management of cholesteatoma and then the post-operative management, imaging management. Okay, so what is cholesteatoma? It's a skin growing the wrong place where you have keratinizing squamous epithelium in the middle ear. Normally you don't have that. And most of this is acquired from repeated middle ear infections. It's a very destructive process. It behaves like cancer, even though it's not cancer. If you leave it alone, it will just destroy, eat up everything. So the only way to treat it is to have surgery. Okay? So how do we diagnose cholesteatoma? It's actually a clinical diagnosis. It's very important for you all to know this as radiologists, because how does it present? Usually foul-smelling discharge and conductive hearing loss, just like chronic otitis media. But when you do the otoscopy, you'll see like superior retraction pocket, typical for cholesteatoma, and containing keratin. Keratin is very important to make the diagnosis of cholesteatoma. Let me just put my pointer. Yeah, you can see the keratin here. Yeah. So because the keratin, cholesteatoma is very different from any infection in the middle ear, and we'll talk about that later. So what is the role of imaging? Again, coming back to ACEs, aid in diagnosis, not to make the diagnosis, to help to make the diagnosis. Look for complications, extent of disease, and surgical planning. Sometimes the clinician may not find it easy to make the diagnosis because the ear might be blocked by something, or might be stenosed, or the patient not cooperating with the examination. Then they rely more on radiology. But essentially, it's a clinical diagnosis. And what do we use for imaging? CT temporal bones can answer most of the questions that they need from us. And has to be thin slice, less than 1 millimeter thick. Very important. If not, you're not going to miss things. Okay, so how does cholesteatoma look like? So typically, the pars lucida type of cholesteatoma usually occurs in the Prusak space. It's a space between the scutum and the ossicles. And this is a very early cholesteatoma that the clinician sees, but on imaging, you can hardly see anything there. If it grows bigger, you can see the cholesteatoma in the Prusak space, but at the moment, it's not eroding any bone or ossicles. So radiologically, it's non-specific, but clinically, they say it's cholesteatoma. So that's why it's very important to have the clinical diagnosis there. Yeah, because if not, it's difficult. You can see how difficult it is to make the diagnosis of cholesteatoma on imaging. But when the cholesteatoma gets bigger, yes, it's very obvious. We know this is cholesteatoma because it erodes the bones and the ossicles. There's blunting of the scutum here, typical epitympanic disease, and can involve the mesotympanum here. And then if you leave it longer, this is what happens. It erodes all the middle ear cavity. You can see the ossicles almost gone compared to the normal side where you have the ice cream cone. And then it makes its way towards the mastoid, and you can see that widening of the adductus. You see normally the adductus is quite narrow, like an hourglass shape, so all that, and then it goes into the mastoid. And then if you leave it longer, it starts eroding the bones and the mastoid, like the sigmoid plate, the lateral cortical bone, and also the medial cortical bone, where it comes into contact with the bony labyrinth and the facial nerve canal. So that you need to operate as soon as possible before it comes to this stage. Okay, there are complications now. So cholesteatoma not only erodes the ossicles, it can erode the lateral semicircular canal. So you get lateral semicircular canal fistula, as seen clearly on the CT. So the semicircular canal comes in close contact with the cholesteatoma. The patient has unretractable vertigo and the urgent indication for surgery. Facial nerve can be involved. So like this case, a nice case to demonstrate that. So on the normal side, you can see the tympanic facial nerve, and you can see the thin bone outside it. Yeah, and on the CT coronal as well. Whereas on this side, it's gone, isn't it? You can see all the cholesteatoma, then you can't see the bone, and even the coronal, you can see the cortical bone, that's gone as well, yeah? So that's another complication. So now we move on to extent of disease. CT, when you have a CT like this, quite easy to know the extent of disease. Something that's quite simple there or very extensive. You don't need any more imaging. But if you have something like this, where the cholesteatoma is in the middle ear cavity and eroding the ossicles, but is it actually eroding the mastoid? I can't see any bone erosion in the mastoid, but it's important for the surgeon to know whether there's mastoid involvement. But I can't tell that on CT. So we do DWI, and you see cholesteatoma lighting up in the middle ear cavity. And why they light up? Because of the keratin. Remember I told you about the keratin? So on the B1000, the middle ear cavity is lighting up, but in the mastoid, there's nothing, yeah? So this patient, the cholesteatoma is only in the middle ear cavity and not in the mastoid. That's good news for this patient and surgeon, because the surgeon can just do an atherectomy and just clear the disease in the middle ear cavity without going into the need to do a mastoidectomy. So that's where DWI plays a part. So HRCT also to demonstrate anatomy, and these are the normal variants the surgeon needs to know to plan surgery. Normally they drill the bone from the back to the front if they're doing the mastoidectomy, and like in this case there's a lateralized sigmoid sinus. You know, if they are not aware of it, it can cause intracranial bleed. Yeah, so all this also we need to look for. So management, usually surgery, and if it's small like the one I showed you earlier, you can just do an atherectomy. But if it's quite extensive and if it goes into the mastoid, then they have to do a mastoidectomy. And there are two types, the canal wall down and the canal wall up surgery. Let's talk about the two types of mastoidectomy. So the canal wall down is the traditional one. We start with this first. So where they remove the posterior canal wall and the whole canal and the mastoid are all in communication. And that's what it looks like on the CT. You can see the external canal, the middle ear and mastoid, all in like one common cavity. And the surgeon can inspect it quite clearly in clinic after the surgery. But it takes a longer healing time. They don't need any more imaging to look for recurrent disease. So that's the advantage of the residual disease is less common in this approach, and it's easy to detect and microsection in clinic. But the problem is the problem for the patient, because they have to have water precaution, and also difficult to have osculation reconstruction. So more and more surgeons are now going on to this canal wall up procedure, where they leave the posterior canal wall intact. So like on the CT, that's how it looks like. The posterior canal wall is intact. So you have a mastoidectomy and a canal wall up mastoidectomy. And why it's good? Because easier long-term care. The patient can wear hearing aid quite nicely. You can do ossiculation reconstruction quite nicely. And they can just go swimming and all that, no problem with this. Especially it's a common disease in children, and they want to have a good lifestyle. So that's why this is a good technique. But the problem is because it's not an open cavity, it's more difficult to detect residual disease, and also at a higher risk of residual disease as well. So after the surgery, usually we do 9 to 12 months mandatory relook surgery. That's what they used to do in the past, until imaging came along, and if we found a technique that can help with imaging, and this is the technique that's been evaluated. So far, we start with CT, useless. Delayed contrast MRI, not very helpful. Echoplanar DWI, not really helpful. And then we came with non-echoplanar DWI in 2005, and that was very promising. And so non-echoplanar imaging is the imaging modality of choice for detecting postoperative cholesteatoma. It's so good, it can detect cholesteatoma down to 2 millimeters. And you don't need to give contrast scans with this technique, because it doesn't add any value. So it's good, it's actually a non-contrast scan, and we're dealing with children and all, that's even better news. So how does it work? Because of the keratin content, again, It has restricted diffusion and high T2 shine effect without high DWI signal. So we normally do two B values, B0 and B1000, and bright on B0 and bright again on B1000, and low ADC values. So we need all these three to make the diagnosis of radiological diagnosis of cholesteatoma. High, high, low. Yeah, very important. And you can do ADC values. ADC values have been shown to support the clinical observation, the radiological qualitative observation we made earlier, that cholesteatomas have lower ADC values than non-cholesteatoma. And usually ADC values like below 1,300 or 1,000 is quite a diagnostic of cholesteatoma. So now, you make sure you use the non-echoplanar type of imaging. So I'll just show you why. So this is a nice haze non-echoplanar. You can see there's no distortion, there's no airborne artifacts, and the cholesteatoma is nicely lighting up there. This is the echoplanar EPI, the DWI EPI. You can see it initially, the very grainy, there's a lot of distortion and a lot of artifacts that can be miscalled as cholesteatoma. Even the latest type of EPI, DWI resolve, you can still see a lot of artifacts which can be misdiagnosed as cholesteatoma. So I wouldn't advise EPI, DWI for cholesteatoma. Use non-EPI, and most scanners will have it, and that's how you can see how beautiful, no distortion, no artifacts. Yeah. So what's the protocol I use for non-echoplanar DWI for cholesteatoma? We need to have anatomical scans like the T2 and the T1 rated images, and we do all coronal, and then the 2 millimeters fine slices, because if not you're going to miss small cholesteatoma. We have B0, B1000 DWI and ADC map. Whole thing takes 15 minutes to do. Very easy, quick to do. Children can tolerate it very well. No IV contrast, no radiation, perfect scan. Yeah. So tips for scanning, this for radiographers. You have to use 2 B values to get the ADC map. If you use one B value, it will limit qualitative radiological interpretation, and you can't have the ADC map. Patient need to keep still, because if not, there will be slice position misregistration, and your ADC map will be inaccurate. But it's a short scan, and most patients can do it. Always keep slice thickness less than 2 millimeters, yeah? Because if not, you're going to miss small cholesteatoma. Coronal scans demonstrate tympanomastoid anatomy very well. Epitympanon, mesotympanon, hypotympanon, you can see it very clearly. Always use T1, T2 for anatomy, because you want to make sure that the restricted diffusion you are seeing is in the middle ear cavity and not outside it. Yeah, cholesteatoma is always in the middle ear cavity and mastoid, not outside it. And then the most important thing, to copy reference all this image for slide positioning. Yeah, so when you report, all this will be the same position, like what I'm showing you here now. All these are in the same position. So the radiographers need to copy reference for slide positioning. I can't stress how important that is. Okay, so once you get this registered for slice positioning like this, you can see T1, T2, B0, B1000, ADC map, all the same position. So you've got this lesion here in the mastoid, which is low T1 signal, high T2. Now B0 is high, B1000 is high, and ADC is low. So what is this? Cholesteatoma. Yeah. What about this one? Here, and below in the mastoid, high T1 signal. No, cholesteatoma is never high. T1, high, bright on T2. Now, B0 is bright, but on B1000 disappears, and therefore has a high ADC value. So this is not cholesteatoma, this is fluid. So you can see how well the DWI differentiate cholesteatoma from non-cholesteatoma material. So this is a nice table to summarize to differentiate cholesteatoma from non-cholesteatoma. And typically cholesteatoma below T1, high B1000, and low ADC. So this is a nice table for you to diagnose cholesteatoma from non-cholesteatoma. If you want to take a picture of this table, it's a good table to take a picture of. Okay. Right? Good. Okay. So now it's not just about detection, yeah? So there's more value for DWI than just about detecting cholesteatoma. It's about, you can actually depict the size and location, so especially for surgical planning. So this patient, high B0, but only a small bit of its high B1000 and low ADC values, only a small bit of that is cholesteatoma, and that corresponds to 4 millimeter cholesteatoma. The rest of the things around it is non-cholesteatoma. So it's been shown to have good size and correlation, good accuracy and localization, and both of this makes it excellent for surgical mapping. So it's a very good tool for surgeons to use actually when they do surgery. But again, on the DWI, it can be quite difficult to look for the anatomy to know exactly where the cholesteatoma is. So what we do, you use the lateral semicircular canal, which you can see well on MRI, as a landmark. And let's go through that. So initially, when you come from front to back, the things in the front is the cochlea, no? So anything at the level of the cochlea, the middle ear cavity here, you can see on CT, it's all middle ear cavity. So if you see a blob there, it's in the middle ear cavity, and that's in the epitympanum. And then if you go back to the anterior limb of the lateral semicircular canal, now this is important because anything on top here, like this thing here, is in the mastoid adductus, you can see it, the corresponding CT. And anything below the anterior limb is in the posterior mesotympanum, retrotympanum, like here. So, and if you go further back to the, anything above there will be in the adductus and below be in the retrotympanum. That's still at the level of the lateral semicircular canal. And if you go behind the posterior limb of the lateral semicircular canal, it's all mastoid. So if you see a block behind the lateral semicircular canal, it's all mastoid. So you can say, okay, the cholesteatoma, this one is in the middle ear cavity and gone all the way in the mastoid, and therefore the patient will need to have a mastoidectomy. And so the surgeon knows it's a big operation. He can counsel the patient, a long operation, and therefore more complications. So it's a good way to, if you can use a fusion, you can fuse the B1000 onto the CT. You can do unpacks, and you can get good fusion images. That's good to demonstrate the cholesteatoma with relation to the bony landmarks and localization. So something that can be done too. So how well is DWI in detecting cholesteatoma? So the largest meta-analysis, 1,152 patients with 26 studies, so a very good sensitivity of 91 and 92. That's very good diagnostic performance over 90, but it's not 100%. So there are limitations, even though it's not as a big limitation, but there are limitations that we need to recognize, that false positive and false negative. So the lack of sensitivity of false negative is mainly due to small cholesteatoma. Because when the cholesteatomas are less than 2 to 3 millimeters, they haven't got enough keratin to return the DWI signal. Therefore, you can have false negative scans, like here, negative for cholesteatoma, no bright signal on the B1000, and on surgery they found a small cholesteatoma pearl less than 2 millimeters. So that's the main reason for lack of sensitivity. So if you have a negative scan, you can say, okay, that's highly likely there's no cholesteatoma, but we can't be sure 100% there's no cholesteatoma. So what do we do? So a lot of it depends. Then the surgeon will have to think, okay, what the risk of leaving a small cholesteatoma behind? So if we are dealing with initially an extensive cholesteatoma and very hard to clear the disease, or involvement of high-risk subsites, especially the posterior mesotympanium, quite difficult to clear the disease where cholesteatoma can hide, or if the surgeon is not very confident that it's cleared the disease, then okay, you can take the patient back for second look surgery and to clear the disease and whatever. But you can, and then so. But if you have if the surgeon is happy with his clearance and it's a small, not that extensive or complicated cholesteatoma, he might opt for serial annual DWI. So it's okay, instead of taking the patient back for second look surgery with the general anesthetic cost, then a lot of patients don't want to go back for second surgery. So let's do a DWI in another year's time and see if it's any cholesteatoma growing and showing signal. So that's the thing, to allow time for the cholesteatoma to grow and demonstrate some DWI signal because they have enough keratin. So you can normally we do serial DWI for up to 3 years just to make sure that we are not missing any cholesteatoma. But the problem with follow-up is lots of follow-up to patients. Patients might not come for follow-up MRI, or the surgeon who don't understand the limitations of DWI may forget to request another DWI follow-up scan. So that's a big problem. So this I show you one case. Patient had surgery in 2011, and that's the initial cholesteatoma. And then 1 year later, 2012, negative. 2013, for some reason, the patient didn't have a follow-up. And then 2014, the patient saw the doctor in the clinic. Doctor was happy. The ear no discharge patient happy, but the DWI, look, cholesteatoma. Yeah? So even though you can have residual cholesteatoma, the patient might be clinically asymptomatic, happy, doctor's happy, but DWI say, hang on, there's something going on here. Patient was operated and there was cholesteatoma. So that's the value of cholesteatoma. You need to always recommend annual follow-up for at least 3 years. If you think very complicated cholesteatoma, you want to go longer, you can go. So what? There's no radiation. It's an easy scan to do. The cost is not so much. So false positive is less of a problem than false negative. Yeah. So the main cause is proteinaceous fluid and inflammation. And that's quite easy. So for example, like here, we have a false positive signal in the mastoid, but it's high on T1. So cholesteatoma is not high on T1. That's why I always do T1 weighted images. So this is proteinaceous fluid. Yeah, proteinaceous fluid can be high on T1. This one, again, got two parallel lines of restricted diffusion in the B1000, but you did the T1 and you see it's outside the middle ear cavity and mastoid. This is actually in the external canal, so it's wax. The wax also has keratin. So this is just wax. It's not cholesteatoma. Don't worry about it. Okay? So it's the T1 beta images are important. Anatomy is important. Okay, so manage in pitfalls and specificity, use T1 and T2 beta images, discuss at your clinical meeting, and if you're still not sure, this is false positive or not, just do another DWI in 6 months or whatever and see if it grows, or if this disappears, then it's false positive, So I'm ahead of time for a change. So coming to a conclusion, so there are two scenarios here. The primary cholesteatoma, clinical diagnosis. I can't stress how important that is. High-resolution CT is the modality of choice, and DWI takes a secondary role. Okay? Now, when you go to postoperative cholesteatoma, the tables flip. Yeah, non-aquaplanar DWI is a modality of choice. And then be aware of the limitations, especially lack of sensitivity, and the strategy to manage them, follow-up scans if you're not doing second-look surgery, and then CT for surgical anatomy if you need it. Normally, you can go by the old CTs, that's fine. Now, can I also recommend, before I finish, this paper here is a very nice review article which I've written about the image management of postoperative cholesteatoma, talking about DWI. So any of you are interested, it's published in Insights of Imaging. I recommend you read this paper. Thank you for your attention and having me here in Nepal. There's a nice sunrise view in Pokhara. You can see the Himalaya mountains there in the background, sun coming up, and this is the Pokhara Lake. And enjoy these pictures I've taken from Pokhara. Thank you so much for having me here.